Hello and welcome to a special forum from Flinders University. It's my great pleasure to welcome all of our alumni, staff, students to a forum on COVID-19. My name's Jonathan Craig. I'm the Exec Dean of College in Medicine and Public Health, and it's my pleasure to co-host this forum with my wonderful colleague, Alison Kitson, who is Executive Dean from College of Nursing and Health Sciences. So we'll do a bit of a tag team. I'll talk a little bit about COVID-19 epidemiology. That's another big word of saying how big of a problem is it and have things been changing over time. And Alison will talk us through what an appropriate workforce response might look like with a particular focus on nursing. So with that, it's really important at all times, particularly at times like this, that we acknowledge the traditional custodians of the land on which we meet. We acknowledge that there are many traditional custodians across Australia and that Flinders has a very large footprint from not only South Australia but into the Territory. But here in Adelaide, on the Adelaide Plains, we pay our respects to the Kaurna people. They're the traditional custodians. And pay our respects to elders past, present and emerging, and also acknowledge all Aboriginal and Torres Strait Islander people who may be viewing this. So I'm going to talk a little bit about epidemiology. Epi is just another word of people. So there are some caveats. You could imagine that, as you can see, I'm not Brendan Murphy. He's the Chief Medical Officer for the country. I'm also not Nicola Spurrier, who's a wonderful associate with Flinders University. She's the Chief Public Health Officer of South Australia. So I'm not going to provide advice. I'm also not going to provide individual medical advice. And you'd also recognise that this is a very rapidly evolving field. This is some data sources from Department of Health, SA Health, WHO, and we've got some fabulous colleagues in the Epi and Biostats department who've made a fabulous contribution. So, firstly, some simple maths, and I appreciate that we've got a very diverse audience amongst you, and some of you have got highly developed math skills and others perhaps not so. But it's important that we understand the numerator and denominator, and they both matter. So the numerator is the thing above the line and the denominator is the thing below the line. So above the line, that's the numerator. This is the number of people who could get COVID-19, and the big N is the number of people who get it, is the top one, and who could get it is the bottom line. Just imagine a perfect scenario where everybody is tested and we have a perfect test. Well, let's say in this hypothetical case, 10 people are found out of a total number of 100 or 10%. In scenario 2, not everybody who should be tested is tested, and we might also not be testing them, use the appropriate method. So instead of finding 10, we end up with finding only 5, but we've still got the same population. So in this case, we end up with 5 out of 100 or 5%. So just a couple of technical terms. This ascertainment bias is when only some of the cases are looked for, so not everybody is found. And measurement bias is when we don't use the perfect test to identify. So what are the various metrics or terms that are used? The first is incidence, which is the number of new cases. Then we have the total number or the accumulated number. Then we talk about the prevalent cases. So let's say we have 100 people and 5 people get COVID-19 in day 1, and 5 in day 2, and 5 in day 3. So the incidence, which is the number of new cases divided by the total number who could get it, is around 5 per day or 5%. Now the incident cases, that's important because that's the first thing that is going to go down in response to interventions that are undertaken. The cumulative number of cases, or the total number, is 5 plus 5 plus 5, which is 15 out of a total of 100. So that's 15%, which gives us a sense of how effective the whole public health control has occurred. The prevalence, which is the total number of cases at any point in time, in this hypothetical is 12 over 100. It's 5 plus 5 plus 5, but in the meantime, 3 people have recovered, so that's 12%. Why is the prevalent number important? Well, that's the number who the healthcare system needs to manage. That's the number of intensive care beds. That's the number of people that general practitioners and other specialists need to be looking after. So I know COVID-19 is all throughout the media, social media, scientific media, but we thought important that we're all on the same page. So what we're talking about is a coronavirus that has had a mutation. The normal coronavirus used to give common colds, right? Very mild respiratory infection. Now, this mutated coronavirus, which is called SARS-CoV-2, that's the name of the virus. It's a bit like mono and Epstein-Barr virus. So Epstein-Barr virus is the virus that caused the problem. The clinical disease, if you like, is mono. So COVID-19 is the respiratory disease that occurs as a result of SARS-CoV-2. Why does it like the respiratory tract? Well, the virus attaches to a specific receptor in the respiratory tract. That's where the problems occur. The median incubation period, that is the time between getting exposed to the virus and actually manifesting in symptoms, is between 5 to 6 days, but there is a range between 0 to 14 days. And that 14 days is the threshold that government has used to say you must self-isolate for that period of time because that's the upper limit. How does it present? Well, unlike a standard cold, which just presents, say, with a runny nose or a bit of a cough, here it causes flu-like symptoms with cough, fever, breathlessness. So we have to also consider that the effects of any public health measures aren't going to occur instantaneously. It's not like going to a lottery event where you spend your money and you know immediately what the consequences are. In this case, there is a delay between any public health interventions might occur and, firstly, with new cases, that delay is about 1 to 2 weeks, and then in 4 to 5 weeks with total cases. Why? Because, as I said before, it takes about a week for the disease to become manifest if you get infected, and then 3 weeks to recover. So inevitably there is that delay. It's spread through droplets, aerosols, and this marvelous word called fomites. So my phone or my case here is a fomite. A fomite is just an inanimate object on which the virus might alight, either because of direct transmission, hands, for example, or coughs, sneezes, etc. And it might last, depending on the surface, up to 3 to 4 days. So what's the situation status internationally? A couple of quick slides. This is up to date as of the 8th of April, and so it's about 24 hours out of date. But you can see that the total number of people affected worldwide is around 1.3 now. It'll be about 1.4 million. And as everybody knows, unfortunately, the outcomes for people who get COVID-19 is sometimes not good, and sometimes death occurs. And at the moment, that figure is around 74,000. This looks at the new cases. So that's the incident cases. The last graph I showed you was the cumulative number. So the incident cases, you can see, peaked at around 80,000 per day, and it appears to be dropping. So that's some good news. So in this graph, it looks at, this is by WHO region. So this is the Europe region, and in the yellow is the Americas region. The graph to the left, that is the China outbreak, which, as you know, was the origin. What about in Australia? So I'm going to spend a little bit of time talking about the situation status in Australia, looking at the total number of cases, the new cases, the deaths, and the number of testing. Now, I'm talking about cases. I I understand and recognize that these are real people with stories and families. So please accept that I'm talking about people as numbers, but I completely understand that that's not a true representation of how important that they are. So as of yesterday, there were about 6,000 cases through all the states and territories in Australia. As you know, there have been more cases in New South Wales than other states and territories, around 2,700, which is about 45% of all cases. The number of deaths, I think, has climbed in the last 24 hours to be above 50. So this is a graph of the cumulative number that have occurred over time. And as you can see, and somewhat ironically, this graph started on my birthday on the 4th of March and increased over time. Firstly, logarithmic, so that means that the rate of increase was actually increasing over time, so it was doubling every 3 to 5 days. And now, more recently, we've had linear flattening in this part of the curve, and then more consistent flattening more recently, particularly over the last week. What about looking at the number of cases a little bit differently, in this case by state and territory? New South Wales is in the blue, South Australia is in the dotted line. The NT is not here, not because it's not important, of course it's very important, but it's the number of cases is substantially lower than other state and territories. Now what you can see on the y-axis, I should say, is a log scale. So those lines you can see is 1,000, 2,000 and 3,000. Why do we have a log scale? Well, that allows us to make comparisons which have very different numbers. So in South Australia, as you know, the total number of cases is 400, whereas it's close to 3,000 in New South Wales, and a log scale allows us to make those comparisons easier. Note also on the x-axis, it's from days from 100 cases. Why days from 100 cases? Well, you'll know that New South Wales, the pandemic started in Australia there, and there was a lag phase before it spread throughout Australia. So if we take it back to 100 days, it's again making a fair comparison. Everything starts at that point of time, and think of a relay race is an analogy. Put another way, this is not the total number of cases, but the total number divided by 1 million. Why do we do that? Well, because South Australia has got a much smaller population. We want to make a fairer comparison with New South Wales, which has got a larger comparison. So to do that, we standardise per million population. And we can see if we do that New South Wales has got the highest number of cases per million at about 320 per million. South Australia, you can see, is number 2 on this at about 220 per million. Why is South Australia higher? Well, we'll look a little bit later, but this has to do with the so-called ascertainment bias or testing. So this is a very important graph. This graph displays on the x-axis days, again, sadly from my birthday, the y-axis, the total number of cases that have occurred over the last month. And as you can see, there was a logarithmic increase towards the end of March, flattening, and now a reduction in the new cases. So there are still new cases happening, but the number is substantially less than previously. Now note, there's a little bit of wobble. It's not a completely smooth curve because there will be better days and not so good days. Why? Because sometimes there will be a cluster that occurs, so that's a real thing. And sometimes it might be, for example, that people don't tend to get tested on the weekend. They say, oh, Monday will do. And so we might expect some sort of noise largely for that reason. So there was an increase, there was a flattening, and then there has been a real reduction. Now, and new cases, as I said before, is the first thing that is going to manifest as a response to the public health measures that all of us have experienced over the last month. This graph tries to unpack why these changes have occurred. So there, as you know, government, both state and federal, have made a number of policy changes in relation to how isolated as a country we are or as a territory or state we are. So firstly, on the 15th of March, gatherings of 500 people were cancelled. Travellers arriving must self-isolate. As I said before, there's going to be a lag that occurs over about a week. And then that effect would continue thereafter. The next thing that happened on the 20th of March, the border closes to all non-residents. Again, a delay, but some starting to see some impact in terms of the interventions that would occur. Not immediately, but a short delay because of that incubation period and a chance for these changes to set in. Then there was closure of clubs, cafes, casinos, and the 4 square metre rule that came in on the 22nd of March. And then the 29th of March, the don't leave the house unless you really need to. You can only have meetings of up to 2 people, and then the 14-day isolation. So you can see that these effects are cumulative and using the population incidence data having some effect. How does Australia compare with other countries? Well, on this graph is plotted the number of new cases expressed as new cases per million population. So we're making a fair comparison across countries which have got very different populations, and also a log scale which allows us to compare countries which have low rates compared to countries that have high rates. This is Australia here in the middle. You can see here increasing up to 10 per million and then starting to fall off. Compared to Spain on the left-hand side, which as you can see is up to 120 per million, Italy around 100 per million, the USA, the curve is continuing to rise, but probably flattening off at about 100 per million. So what we're saying is that those countries have had incident rates 10 times of what we have seen in Australia. The UK, also close to 100 per million. Other countries, particularly Southeast Asia countries, seem to have managed this better. And you can see the rates of increase are not dissimilar to Australia. So what about, what's the sources? And it's very important here that we distinguish the different types of sources for transmission. This graph is from New South Wales, and the black represents sources from overseas, the blue, local known, the green, under investigation, and the very important group, which is the unknown local. That's another way of saying community transmission, and the community transmission is particularly important because that's something that can't be traced and isolated. That's the spread of fomites or other people who are spreading in the community, which can't be isolated. How are we going in South Australia? So the unknown local you can see is down here, and that's always been very small, which is very pleasing. COVID-19 testing rates. Again, this is standardized per population. In the red is in the green, in this case, is South Australia. So you can see over time, the testing rates for all states and territories in Australia have increased, but South Australia is, if you like, the most tested population. About 1.8% of the entire population have been tested. New South Wales also increasing up to 1.4%. Tasmania, you can see, is increasing, but started from a very low base. How are we going compared to other countries? So the black is Australia. There are a couple of countries that have tested more. Norway and Switzerland, you can see, are closer to 2%, 1.2% in Australia. What about deaths? So obviously, deaths are something that everybody is very keen to avoid. How are we going in Australia compared to other countries? And again, this graph shows you Australia here compared to Spain, Italy, the US, UK, and South Korea. It's in a log scale and again standardized for fair comparisons. So this is the daily rate due to COVID-19. In Spain, top left, peaked at around 20 per million deaths due to COVID-19. Italy, as you know, was also very affected, 10%. The US rates are going up at around 5 per million. This is Australia. Please ignore the kind of curve there. The rates are increasing. You would expect that because the average time, the median time between infected and dying with COVID is around 2 weeks. So there will be a delay period, but you can see rates of about 0.1, which are 100 times less than countries, particularly in Europe, and pretty similar to rates in South Korea. So, in summary, apologies, but I thought it would be very helpful just to go through these data in some detail. My summary is that it's promising, but it's early days, right? The number of new cases are falling internationally and particularly in Australia. Now, as you know, the number of new cases is less than 100, which is about what it was 3 weeks ago or a week after my birthday. The total number of new cases will eventually fall, right, assuming current trajectories occur, but there will be a lag phase because, as I said, it takes about 3 weeks for people to recover, and a new case only eventuates in 5 days. Community transmission rates are low and also falling. The number of deaths in Australia are too high by any means. I mean, we clearly do not want any deaths, but in Australia, they are very low by international standards at about 0.1 per million per day, or an overall case fatality rate of about 0.8%. And as I said before, testing rates are high by international standards. What about new research? So I'm not going to go into any detail here, but what I would say is that this has been an absolute hive of activity. We have a very highly developed health and medical research community in Australia and internationally, and every person is putting their shoulders to the wheel of identifying new interventions that might prevent this occurring, or if it does infect somebody, improve outcomes. There are 366 trials which are registered on this website, clinicaltrials.gov, which is an online portal. Last week that number was 239, right? The number of new trials that are coming online, that is exponentially increasing. There are 27 vaccine trials. Last week there were only 18. So what's this all about? And I know you've seen this curve, but just to emphasize it again, this is about reducing the so-called R0, right? So that is the number of people who get infected by a case. So the number that we saw early on, particularly in China, was 2 to 3. So that means every person infects potentially just 2 to 3 people, and they infect 2 to 3 people, and that's why you get the logarithmic increase. If that number, the R0, gets below 1, then we're going to have a reduction. So it's about flattening the curve, which means fewer people infected, and the healthcare system can cope with the crisis. What do? Well, we need to physically distance. You will note that even though Alison and I are absolute colleagues in health-related area, we're now 1.5 meters apart. Why is that 1.5 meters apart? Well, that prevents or minimizes, I should say, aerosols or droplets that might occur coming into the respiratory system of somebody else. Why hygiene? Hand washing, avoiding the face, because that's our fomite problem. Now I'm going to ask Alison for a little assistance. Alison here. So you need to stand, right, like this, and we need to do the twirl, right? So this is the twirl, because you know that the arm span is about the size of an average person. Size of an average person is about 1.7 meters. Double the arm span, you'll know that you're in a safe location. Do the twirl, do the twirl. The final thing I would say is that this is a marathon, right? We thought it was a sprint, but this is a marathon. The interventions and strategies that we need to consider, and I'm sure Alison is going to speak to those at length shortly. This is not about the left-hand side, this is about months, and that's about the marathon. And with that, I will close and look forward to Alison's contribution. Thank you, Alison.
Thank you, Jonathan, and good afternoon, everyone. My name is Alison Kitson, and I have the great privilege to be the Vice President and Exec Dean of the College of Nursing and Health Sciences here at Flinders. And I'm really just going to pick up the action word because, Jonathan and his colleagues have wonderfully explained just the epidemiological and etiology where this virus has come from, what impact it's having on our bodies. What I want to focus on now is what do we do? How is this affecting us? How is it affecting our health systems? How is it affecting our university, our students, our alumni? And I thought it would be good to remind us of one of our, the namesake, Flinders University, Matthew Flinders, who reminded us that actions shall speak to the world. So what sort of actions are we involved in? At the beginning of 2020, I, like the 28 million other nurses in the world, we're looking forward to celebrating a really, really special occasion, and that's the 200th anniversary of the founder of modern nursing, Florence Nightingale. But it's actually very interesting that Florence Nightingale was not only the curator of modern nursing, but she was also statistician, epidemiologist, understood the importance of using data, collecting it, analysing it, and then changing people's behaviour as a result of it. So I think that this, from the auspices of this wonderful social reformer, we actually have such a wealth of knowledge and understanding about how we can make a real difference to the lives of people. And it was in planning how we were going to celebrate Florence Nightingale's 200th birthday, and the WHO designated 2020 as the year of the nurse and midwife, that we in the college decided that we would strut our stuff and decide that our strapline was brave, bold and brilliant nurses and midwives. And I actually would have to say that it was never more obvious that our nurses, midwives, allied health and medical colleagues do have to show these qualities of bravery, boldness and being brilliantly creative in the way that we're tackling this. So, as I said, we have 28 million nurses globally. The reality is that every one of these nurses is going to be impacted by the coronavirus at some time sooner or later. We also know from statistics that we're currently are short of over 6 million nurses globally. We also know that the distribution of nurses globally is not uniform, so that 80% of nurses actually look after less than 50% of the people who need nursing. So again, that gives you some sense, if we're looking at this in global terms, what impact coronavirus is going to have on some communities than others. Also, now it was a bit harder to get the total number of allied health professionals, and I'm hoping there's somebody who's listening will tell me what the accurate figure is. But it's probably around 7-8 million allied health professionals globally. But they also reckon that they are at a deficit of around 2 million. So already we're actually knowing that our workforce capability and capacity to deal with this pandemic, this global impact is challenging us. Equally in Australia, We have over 360 registered nurses. We have just under 200,000 allied health professions. And we know that both of these groups, allied health, make up 30% of the workforce and nursing attributes 50% of the workforce. Now, we also know that within our own alumni and across Flinders, we actually have over 25,000 alumni are from nursing and allied health. And we've got, out of the 40,000, we've also got 9,000 alumni from medicine and public health. So that is one significant group of thought leaders, of people who embrace this notion of taking action. Action based on the best evidence, action based on careful, logical, thoughtful, analytical response to a crisis that none of us ever thought that we would ever experience in our lifetime. So really the important thing for us as Flinders staff, as Flinders alumni and as Flinders students is really to think through how are we going to best get through this situation and look after each other and look after our patients, our communities and our greater society. So here's an example of, I didn't know it was called doing the twirl, Jonathan, but here are some of our wonderful international first-year nurses who, despite the chaos, the change that has taken place, just think of what it must be like for someone who has left their home and is now in a strange place, not able to go out, and all of their dreams, their expectations of what their first year or their third year or their final year at university was going to be like. These guys are building resilience like no other way that they could get it. But just think what the workforce is like for our students and those of our students who will be still going into clinical placement, finishing off their degrees. Here is a picture of health workers in Spain, where it's both an acknowledgement of those people who have been infected, but equally those health professionals who have lost their lives. We know from listening to WHO that there is a growing shortage of face masks, of protective clothing, of tests. So we also need to make sure that our governments right around the world are actually making sure that the people who are in the front line looking after our sick COVID virus patients and those who are very ill in intensive care actually have the right equipment. We also know that we're already seeing signs of stress, of fatigue, of people just not having experienced the relentless pressure of working in the ICU, of having to deal with multiple deaths. Again, these are things that we have to be thinking about, and thankfully, the great work that Australian public health people are doing is stopping that from becoming a reality for us. But in considering the impact that coronavirus, the pandemic will have on us, it's fair to say that the way that we deliver healthcare, the way we interact, the way we do business is changed forever. These are some of the changes that we reckon will come out of the pandemic. It will of necessity help us or require us to rethink about how we work as teams, how we rebalance the way we do business. Think of the impact telehealth is going to have. Think of the impact that the whole range of other workers is going to have. We will be developing and testing new models of care. So just as Jonathan was talking about the incredible surge of research in virology and immunology and all of the clinical trials. So we need to be really coming to terms with how we're going to change our health systems and our social care systems, that we don't, that we can ensure that individuals, families, communities know this basic stuff about hand washing and social distancing and looking after themselves. Because you know what, it's come as a bit of a surprise to a whole pile of people that you can get this sick just by, you know, staying close to someone. So we also need to be thinking about getting more men into nursing. Like, think of the 28 million, mostly women across the world, who are going to be on the front line. Their mothers, their sisters, their daughters, they've probably got loads of other caring responsibilities. So what we need to be doing is making sure that we sort of have a workforce for the future that is not skewed or biased to one group. We have to make care matter, and we have to generate the evidence base around caring and self-care and caring interventions. And this is where the work that we're doing at the Caring Futures Institute is really speaking to this step change that we need to have in the way that we think about care as an intervention, care as an evidence-based set of skills that we need not only our nurses, allied health and medical colleagues to have, but also something that is fundamental and foundational in the way societies are care for each other, our social care, our aged care and our child care systems. So in our college, we have already begun to respond to a number of initiatives around the impact of COVID. We're looking particularly at disadvantaged and marginalised groups in our community to see how they are coping with the isolation, with the lack of information. For example, how do we know that people from an ethnic group are getting the information in the language and in the metaphor and constructs that make sense to them? We also have to look at how we understand some of these basic biological and epidemiological constructs in ways that can translate easily into when you're in the supermarket or when you're talking to friends or when you're looking after someone. And that we also, as I said, need to be thinking about what the profound changes will be as we move forward. We are guided and supported by great promoters of the Caring Futures Institute vision, and I would really like to pay tribute to two great colleagues. One is Judith Leeson, who is both an alumna of Flinders, but also a great advocate and campaigner for social justice, for inclusion, for acknowledging people who often don't have a voice. And now is the time really to get Judith even more into action. Also would like to acknowledge Daryl Sellwood, who just recently obtained his PhD from Flinders, and he also is a great campaigner for disability rights, for engaging, for making sure that we acknowledge and respect and understand this whole social inclusion agenda, and we're hoping that Daryl will really be able to make a big impact to some of the work that we're going to be doing. And then finally, again, like many students, like many sort of groups, we're sort of discovering that telehealth, even though it's been around for about 20 years or so, all of a sudden we're able to do it. So one of the student-led clinics that we've just developed, that you can see that provides services in optometry, speech pathology, audiology, physiology, exercise physiology, has gone virtual. And so we're going to be working not only with Flinders Medical Centre, with our students, but possibly with a number of local communities to make sure that these services are moved around. But we can't do this alone, and this is why we're really keen for you to, if you're interested in anything that I have said, that Jonathan has said, and that you want to come and get involved, then certainly we would love to sort of hear from you. We would love to continue the conversation, and we want to hear your ideas for how things can move forward. Because this is the little blighter that's been causing all this damage. But you know what? This is what will happen to it. Thank you.
So, thank you so much, Alison. I think that's a perfect segue from not only just describing the problem, but what we as a collective are going to do about it. So, we're now going to move to some live question and answers. So via the team site, if you want to submit any questions to us, we will address them wherever possible. If we're unable to address them now, then we'll record them and we'll get back to you at a later date. So Alison, I think this is the first one for you, and I think you've addressed this to some extent, but the Caring Futures Institute will play a pivotal role in the community during this pandemic. What are your thoughts about which are the primary ingredients for our recovery? Because you put the cross through, so you know there's going to be a standout eventually, and how we're going to prepare for it.
Thanks, Jonathan. So, yeah, I think the first thing is to hold that belief that there is going to be a recovery. We will recover. So that's the first thing. Second thing is that we should use this time of strangeness as a way of beginning to go back and understand what are the important values in life, in community. And I think these, certainly for me as a nurse, I know that the most important value is that ability to engage in a trusting relationship that is based on care and reciprocity, and enabling people to do what they want, be kind, be generous, but do it in a way that is evidence-based and helps people move forward. So in the Caring Futures Institute, that's what we're trying to do, to really unpackage how care is delivered, how we then can build it up, and how we then can do that in collaboration, in partnership with the people who need care. And guess what? Everybody needs care from the minute you're born to when you shoot out the other end in life. You will need to have people who look after you, and professionals only do a small amount, and it's how we're trying to increase that care literacy. That's what we're doing with Caring Futures.
So another question, how is the university helping in the fight against coronavirus, either through research or practically? We're situated next to Flinders Medical Centre. That's on one campus, but bearing in mind that we've got campuses throughout South Australia and into the Territory, how are we helping them? Is there any way that we can envisage staff helping? So I might have first go and then hand it over to you, Alison. So Alison, I think, has spoke to the research that's happening. Similarly, in nursing and health sciences, with the fabulous contribution of the Flinders Foundation, we've had a research round, and that's showcasing all sorts of possibilities. So vaccines to prevent COVID-19, SARS-CoV-2, through to real-time access via an app, which Niranjan Bidagadi is seeking to implement, which could do a number of features, indicate, assist health authorities in terms of managing cases, in terms of surveillance and isolation, through helping people who are affected with COVID-19 record how they are going over time, potentially about using this technology to de-escalate the isolation activities that were happening. For example, if we know where the different areas of COVID-19 is in, say, Adelaide or South Australia, then potentially we know areas that are safe and that people can repopulate those areas. Other interventions that we're working with Salin in partnership, or Flinders Medical Centre, which is real live tracking access of all patients who've got COVID-19 and following them over time. The other practical things we've done is that we are co-located, so we're allowing Flinders Medical Centre to use a lot of our spaces. They need to socially distance. To do that, they need additional spaces, and so we're very happy to contribute to that. We've also contributed personal protective equipment. We've donated some masks. I mean, I think that just to follow up on what Alison said, this does showcase what the marvellous partnership that we as a university have with healthcare providers, right? We need research, we need education, we need frontline healthcare workers. And this really, in many ways, I think has demonstrated how much those two institutions have worked together. Alison, anything?
Yeah, and again, just some very practical things. Our final year nursing and allied health students, again, are still continuing their clinical placement, and that was very much a decision that both SA Health and the university wanted to make sure that our students were out experiencing what this was like, but also providing support. We've also had students doing placements with SA Pathology, manning phone lines so that they're able to provide advice. We've talked about the telehealth and using our Health to Go clinic as a way of starting to provide outpatient clinics that would have been held in FMC. How can we provide additional support so that the nurses and allied health professionals can actually do that frontline work. We've also been talking about how we can skill up registered nurses to get a quick course in intensive care nursing. And we've also been thinking about how we can get some of our graduates who've graduated in this last year or so, who maybe are not working in nursing but want to respond to the call, to come back into the workforce. So those are all the really practical things we're doing, as well as starting to think through the longer term workforce redesign work, the longer term evidence around caring interventions. And let's be clear about it, we're still not all good at washing our hands. So if we were able to make sure that everybody washed their hands according to the evidence, that would be an incredibly big first step.
Alison, there's another question for you, which is some universities have pulled out nursing and medical students from placements because of COVID-19 when we appear to need them most, right? Given what's known in Australia and worldwide shortage of nursing. So do you just want to talk us through the rationale of continuation of placements?
Yes. So again, for me, and I'm sure for you, Jonathan, as well, we know that actually, this is something none of us could have foreseen coming, but it's part of what you have to be able to cope with and manage when you are both a health professional and when you are training to be a health professional. So we very, very much take the view that working with our health partners, how do we best support the student, and particularly we've targeted our final year students in nursing, midwifery and allied health, so that they actually experience what will be an incredibly important learning experience for them. And these are certainly, I can't speak for other universities, but certainly for our university, this was something that without any dissent, everybody felt it was the right thing to do.
So on the medical placement side, let's be very clear here. Everywhere from the Commonwealth Department of Health to all of the state health departments across New South Wales and the senior leadership of all the clinical care providers, there has been a unanimous view that medical placements, clinical placements more generally could continue. Why? Well, so ultimately we are accountable to the community, right? We are training the next generation of clinicians. I think that the community would want us to train the next generation of clinicians to cope with whatever comes around the corner, and that includes a pandemic, right? This might be new to Australia, but let's not forget the influenza epidemic, the Spanish flu. Let's not forget SARS in 1990s. Let's not forget MERS. These were both massive epidemics in the countries that affected. So we take our accountability to the public and ensuring that we develop a fit-for-purpose workforce very seriously. The second reason is that, you know what students want? They actually want to graduate, right? So the problem with withholding clinical placements is that puts them in a very difficult position, and us as the custodians of their education in a difficult position, because it then becomes uncertain how they are going to get their clinical learning, particularly in the current environment. So without, of course, the doctors in training, the medical students, the nurses want to make sure that we have appropriate safeguards in place so they're not going to particularly high-risk situations. That is what we can do, and that's what we have done. The third thing is that from a healthcare perspective, students are a very important component of the workforce, right? So even though COVID-19 has reared its ugly head, all of the standard problems that people have had, asthma, heart attack, stroke, all of those people are getting those conditions too. So this is a contribution that the students, as a critical member of the albeit a trainee member of the workforce team, can contribute. And so that's part of that I think provides a perspective of why it's been very important for our students, medical students, nursing, allied health students, to continue to be effective in the clinical placements. So what about, this might be a question for you, Alison. How do we engage with those population that don't have internet or phone access to healthcare? So I think clearly the public, the community, is not a single entity. They're very variable. I think you've referred to some in particular who are marginalised, particularly the elderly, don't have caregivers, maybe those whose first language is not English. How do we engage with them and provide the care that they also need and deserve?
Well, I would say both with difficulty, but with also a significant creativity. And this is actually one of the discussions that I've had on several occasions with some of my colleagues in the Caring Futures Institute. And by the nature of the research work we do, it is going into those places that are looking at vulnerability. So, for example, there's a wonderful piece of work that's being led in Mount Barker by Yvonne Parry, who's one of our nursing academics, and she has actually set up a sort of a particular service for vulnerable children, and is using a nurse practitioner working with Mount Barker Health System to actually begin to quantify exactly the sort of thing that you talked about, Jonathan, because I think one of the realities is that if you don't measure it, if you don't quantify it, then you can't actually do anything to change it. And one of the challenges that we in nursing and allied health face is that we have a paucity of robust measures and robust metrics. I would absolutely adore and love to be able to show all of the graphs and all the stuff around, you know, the impact of caring and the impact of, you know, wearing proper PPE. But nobody's going to do that research because we're in the middle of trying to find a cure. But we also, you know, we will never not need care. So the quicker we get into the mindset that we have to respect it and begin to articulate it, measure it, go to the places where the most vulnerability resides, then that is the way that we'll make the innovation.
So there's a question about, is it known if there's a degree of immunity for people who have recovered from COVID-19? So we know from other viruses and from data in a relatively small group of patients that where they get a good immune response. So the short answer is that one would expect that everybody who recovers from COVID-19, the likelihood of them getting again is very remote. There's a question here about, which I think is a question that probably all of us would want to know the answer for, but I suspect that none of us could provide the answer. How long is it going to take before we go back to our lives again? So I might have first go at that, Alison, and then go to you. So, I mean, you know what, and just to flag a couple of things that Alison's already said, that nobody wants this pandemic, nobody. On the other hand, there are so many positives about coming together against a shared foe. Coming together, I've just talked a little bit about the partnership between our clinical care providers, about resilience, about learning different ways of working, not necessarily being on campus. All of these things that probably would not otherwise not have occurred. We, as you know, as a Flinders University, we went to online in close to 2 weeks. We got research that historically has taken months compressed down to a week or two. So I'm not sure actually that we want to go back to where we were completely. Having said that, of course we want to go and see our family and friends, and we want to travel and all of those things. And that, I think, you know, probably the Prime Minister has got it right, and that would, you know, we're talking about 6 months or so, but really who knows, right? When is the vaccine going to come about? Could this be like MERS and SARS, where actually that effectively didn't continue, even though no vaccine was found? Admittedly, there are very different scenarios here. Alison, what's your thinking? Crystal ball gaze for us.
Well, I suppose I would respond to the questioner by saying, you know, you still have your life. You're living it, even though you might not want it to be the way it is now. So then the choice is, how do we actually optimize the learning, optimize the connectivity? And I think, you know, the whole of the internet is full of the creativity of the human spirit. And just before we went on air, I was actually talking to Jonathan about, you know, Nelson Mandela. So I was thinking, you know, that guy spent 23 years in solitary confinement. He was allowed out for an hour, and he came out the sweetest, most compassionate, and you know, a man who still had his vision and was able to move forward. So it doesn't necessarily need to be all bad, and so that's where you need to dig deep in, think about being kind, being considerate, have a laugh, and see the fun side of this, as well as, you know, the serious ambition to actually find a cure, to transform care, and to get out the other side.
So we've now, that's a great ending, I think, Alison. And so thank you very much on behalf of Alison and me for spending the hour with us. We hope this has been informative. We do value the time that you have spent. All the best for a fabulous Easter.
Yes.
Goodbye.
Thank you. Bye-bye.